Dear audience, dear colleagues, let me introduce you my PhD work. My thesis title is New Insights on the Oncological and Surgical Outcomes After Colorectal Cancer Surgery. I'm Ágnes Fodor. I am a surgery resident in the Department for General Surgery in Szent Imre Hospital in Budapest. My vision is that patients with colorectal cancer receive the best possible therapy, and my mission is to provide scientific evidence for this special population. To achieve these goals, I have two ongoing projects. The first one is investigating the effect of anastomotic leakage on the oncological and surgical outcomes after colorectal cancer surgery. And the second one is investigating the effect of additional intraoperative colonoscopy on the prevention of postoperative anastomotic leakage. My first project started in September 2023. Colorectal cancer is the second leading cause of cancer death in Europe, and anastomotic leakage is one of the most feared complications following colorectal resection. The incidence of it varies between 3 and 30%, and it's associated with severe short-term morbidity and mortality. To evaluate oncological and surgical outcome for patients with and without anastomotic leakage after colorectal cancer surgery is our aim. And the clinical question is if anastomotic leakage affects the oncological outcomes after colorectal cancer surgery. The population of this study are patients with rectal and patients with colon cancer after curable surgery with primary anastomosis, and we compared the patients with anastomotic leakage with the patients without leakage. The main outcomes are overall survival, disease-free survival, local and distant recurrence, and some secondary outcomes of this study are postoperative morbidity, length of hospital stay, and need of ileostomy. Our hypothesis is that patients with anastomotic leakage, so anastomotic leakage is associated with worse oncological and surgical outcomes. We ran the systematic search in the three following databases. Here you can see our search key. And after the selection and the citation chasing, we ended by 66 eligible full-text articles. Here you can see our outcomes. The most of the outcomes are still under analysis. So I would like to highlight disease-free survival, overall survival, local and distant recurrence, and cancer-specific survival, local recurrence-free survival, but we already have some finished analysis, although these are only preliminary results for 5-year overall survival, length of hospital stay, and need of ileostomy. Here you can see the plot of the 5-year overall survival and the pooled hazard ratio. We could include 16 studies in this analysis, and you can see that we have 3 types of papers in this study. First, with patients with colon cancer, patients with only rectal cancer, and patients with colorectal cancer. The result is that the hazard ratio is 1.55, so you can see that if the hazard ratio is more than 1, that means that patients with anastomotic leakage have a worse chance to survive than the patients without leakage. And this means, so our result means that patients without leakage have 55% more chance to survive than the patients with leakage. This result is statistically significant and clinically relevant. The second plot shows us the length of hospital stay in the 2 groups. And you can see the result of the mean difference for length of hospital stay. It's 13 days longer in the group with anastomotic leakage. It's also statistically significant and clinically relevant. Of course, we also have some strengths and limitations of our study. For example, high clinical relevance and big number of population, or high quality data from Kaplan-Meier curves. And for example, a limitation is that most of our studies are retrospective cohorts. The conclusion is so that patients with colon or rectal cancer without anastomotic leakage have a better 5-year overall survival compared to the AL group. And this has the implication that more frequent follow-up for patients with anastomotic leakage after colorectal cancer surgery is important, and so is the role of intraoperative colonoscopy in the prevention of postoperative anastomotic leakage. The first project progress is we are finished with the risk of bias, and we are still waiting for the remaining results from the statisticians. And so we come to my next project, which is investigating the effect of additional intraoperative colonoscopy on the prevention of postoperative anastomotic leakage. As I already mentioned, colorectal cancer is the second leading cause of cancer death in Europe, and anastomotic leakage is a feared complications after colorectal surgery. There are several leak tests, however, their safety and feasibility is still debatable. It's already proven that colonoscopy is a safe method to evaluate the integrity of primary anastomosis, and the aim of this study is to investigate the effect of additional intraoperative colonoscopy on the reduction of postoperative anastomotic leakage. You can see a picture of this intraoperative colonoscopy. On the right side, there is a picture above with an intact anastomosis, and below, there is a picture with, of an anastomotic leakage shown by the arrow. The question is if an addition of intraoperative colonoscopy reduces the risk of postoperative leakage, and the population is patients with left-sided colorectal cancer after curable surgery. And we compare the two methods, air-leak test with intraoperative colonoscopy and air-leak test alone. The main outcome is incidence of postoperative anastomotic leakage, and we hypothesize that the addition of colonoscopy reduces the incidence of postoperative anastomotic leakage compared to air-leak test alone. The clinical and research implication is to reduce the risk of anastomotic leakage in colorectal cancer surgery. Here you can see the summary of my projects. The planned submission date for the first project is in August this year, and for the next project is in February 2025. I would like to finish my presentation with the words of Hanvas Béla. Truth can be found by chance, but no one can be true by chance. Thank you for your attention.
Thank you for this nice presentation. Any questions, please?
Congratulations. I would like to ask about the second topic. What is the practice in Hungary? Do you use this intraoperative colonoscopy at every colorectal cancer surgery?
No, not in every surgery and not in every hospitals. So there are hospitals where they use it after every colorectal cancer surgery with primary anastomosis. And there are the next group where they don't use it at all. And the third group is when they use it if something happens or if there is a question of leakage, if the surgeon thinks it's not 100% safe, or if they think about an ileostomy. Yeah.
Thank you.
Did I understand correctly? You said that colonoscopy, intraoperative colonoscopy, decreases the incidence of the bad outcome of bad oncological outcome.
Yeah.
That's
yes.
colonoscopy itself.
Yes,
How
it's a bit a
would it-
mixture of the two projects because my second project is about colonoscopy as for detecting the anastomotic leakage intraoperatively, so during the surgery. And my first project is about to prove that patients with anastomotic leakage postoperatively have worse chance to survive because of more chance to have a local or distant recurrence.
Okay, I understand
So
now.
worse
'Cause
oncological
not
outcomes
colonoscopy itself, but
No.
recognition of
Yes.
the leakage.
by decreasing the chance of the leakage.
I did ask it in the beginning, and I'm asking it again. In the beginning, I mean a couple of months ago. Does the oncological stage of the disease influence the proportion of leakage? In other words, let's say a population of Dukes A have the same risk for leakage than a Dukes B cohort.
Mm-hmm. So we have approximately 70 studies, and more than half of the studies include subgroup analysis for these groups of patients regarding stage. So we will have results only for patients for stage 1, 2, 3, and so on. And maybe then we can have new information about if, so whether it is a worse oncological outcome because of advanced stage or the leakage alone. So the subgroup analysis will help us, hopefully,
My
in this
theory
question.
is that patients who have leakage are probably at a more advanced stage of colorectal cancer to begin with, and that is the reason why they end up having a worse oncological outlook and not the anastomosis. The anastomosis is just a how do you call it? What's the name for that? A surrogate marker.
Yes, yes, it's a real theory, and I also think that it has an effect. But after the whole analysis, we will see the results of it alone, or if it's an effect, what you are talking about, and the leakage differently. So we would like to separate these two effects by doing the subgroup analysis.
Another important thing is that I believe anastomotic leakage depends on a lot of things. And one of them is the skill of the operator, isn't it?
Yes.
Do you think that anastomotic leakage is a key performance indicator for colorectal resectional surgeons?
Yes, I think so, definitely.
And you are right, and you have to report that in England. And the patient have a right to have a look at your performance.
Thank you.